how do you treat Zenker's diverticulum? Treatment is indicated only if the patient is symptomatic. Asymptomatic patients can be just observed closely, but remember, patients are at risk of aspiration, especially if they are elderly and frail. No role of medical therapy, no role of diet modification. Remember, the medical therapy is not there and dietary modification is not going to work. All the treatment which are effective are invasive and they target the division of cricopharyngeus muscle. We know the problem muscle is cricopharyngeus muscle. It is not relaxing. Okay, and whenever a muscle is not relaxing, then we do a myotomy, and here most of the patients will have myotomy, cricopharyngeal muscle cutting. Okay, so that's why Zenker's diverticulum is sometimes called as achalasia of the pharyngoesophageal region. Okay, we know achalasia is traditionally the lower part of the esophagus is involved, but here you can also say Zenker's is a counterpart of pharyngoesophageal achalasia. It is a counterpart of achalasia of the lower end of the esophagus. Okay, and the treatment here is addressing the cricopharyngeal muscle by doing a myotomy. What are the main three treatment options for Zenker's diverticulum? You can do a open surgery, you can do rigid endoscopy, you can do a flexible endoscopy treatment. Okay, the options with respect to open surgery are diverticulotomy, diverticulectomy and diverticulopexy. Diverticulotomy is you cut the septum and open the diverticulum. Diverticulectomy is you cut the diverticulum, and diverticulopexy is you obliterate the cavity of the diverticulum. So these three are the main options when you are doing open surgery. Let us discuss all these treatment options with respect to Zenker's diverticulum in detail one by one. Okay, the open surgical approach, it is the cricopharyngeal myotomy with or without diverticulectomy or diverticulopexy. Okay, whenever you are doing an open surgical procedure for Zenker's diverticulum, you will do a cricopharyngeal myotomy so that the muscle is getting cut, and you will add either diverticulopexy or you will do the diverticulectomy. The procedure is done under GA. Generally you use the left cervical approach because we know it is most common. The Zenker's diverticulum is more common on the left side. The diverticulum is isolated after you incise the neck, dissect the tissues. You have to do myotomy. The myotomy extends 5 centimeter into the cervical esophagus. Okay, you don't only cut the cricopharyngeus muscle, but you also extend the myotomy 5 centimeter into the cervical esophagus. If the diverticulum is small, less than 1 centimeter, you will just do a myotomy. You will not do anything to the diverticula. If it is a medium diverticula, around 2 centimeter, okay, you may do a diverticulopexy, or you can invert the diverticulum. If it is a large diverticulum more than 3 centimeter, you have to resect it. You will do a diverticulectomy with a linear stapler. Complication of open surgery: cervical hematoma, airway compromise, leak and aspiration pneumonia. This is the open surgical exploration. After doing the neck dissection, you have isolated the diverticula, dissected it free from surrounding structures, and then you are firing a linear stapler to excise the diverticulum. That is called as diverticulectomy. Okay, and you can appreciate the myotomy also has been done. Okay, cricopharyngeal myotomy has been done. You can appreciate that. You have to do both. Okay, and this is the pre-op and post-op picture, the barium picture of patients with Zenker diverticulum and how it looks after surgery. You can appreciate that the diverticulum has disappeared after surgery. Endoscopic stapling diverticulostomy, okay, also known as Dolman's procedure. This can be asked as an MCQ. They have asked this in the past. What is Dolman's procedure? Endoscopic stapling diverticulostomy. Here you use a Virda diverticuloscope, which is a rigid scope. It's done with a rigid scope. Virda diverticuloscope, the procedure is done under GA. It allows direct visualization of the septum between the diverticulum and the esophagus. Okay, so that's the esophagus and then the diverticulum. So this is the septum which is in between the diverticulum and the esophagus. So here you will apply the stapler. And divide this septum. You can appreciate the staple has been fired and the septum has been cut. You can see that V-shaped division. It is after you fire the stapler, the septum gets divided. It is called as endoscopic stapling diverticulostomy. Here you are just cutting the septum. You are not doing anything to the diverticulum. So that's why it is diverticulostomy. Okay. So it generally requires 1 to 2 staple firings based on the size. The risks are dental trauma, mucosal injury and possible perforation. And remember, this is done under GA. Okay. The other option is flexible endoscopic options. Okay. The previous one was a rigid endoscope. You can also do the procedure by flexible endoscope. So what are the flexible endoscopy options? You can do flexible endoscopic septum division, similar to what was done in the previous part of this module, but it is done with the flexible endoscope. In the previous slide I told you it is with the rigid endoscope. You can do the same thing with flexible endoscopic septum division. You can do Zenker peroral endoscopic myotomy, commonly written as Z-POEM. You can also do peroral endoscopic septotomy, POES. Okay. So remember all these terminologies. This can be asked in your exam, Z-POEM or POES. So you don't get confused. Okay. They are all very simple, but the fancy names will confuse you. Okay. So let us understand one by one. So flexible endoscopic septum division, short form FESD. So this is an option for elderly and high risk patients, especially when the rigid endoscopy becomes difficult. It is performed under conscious sedation. Okay. If you are using a rigid scope, you have to do it under GA. But if you are doing a flexible endoscopic septum division, you can do it under conscious sedation, especially if the patient is high risk. Okay. NG tube is inserted. It helps you to expose and protect the anterior esophageal wall. You will use soft diverticuloscopes or over tubes to improve the visualization and protection. Okay, you can appreciate here. Okay, that's the over tube. The cutting device used to cut the septum is either needle or knife or monopolar forceps or hook knife, or you can also use APC. You can also use clip and cut technique. Apply clips, then cut, apply clips and then cut. It decreases the perforation risk. The diverticulum is large. You may have to do stage procedure. The complication of this procedure is bleeding and perforation. Okay, and you can appreciate the flexible endoscopic septum division has been done here. So that's the margins of the cut edge. What is Z-POEM? Submucosal tunneling septum division. So it is similar to POEM procedure in achalasia. A submucosal tunnel is created proximal to the septum. Okay, here is the septum, but you are creating a tunnel proximal to the septum, and this allows complete myotomy, but the mucosa is preserved. It reduces the risk of perforation mediastinitis. Overall risk of recurrence is also low, and the mucosectomy is closed with the clips. Okay, at the end of the procedure, the mucosectomy is closed with the clips, similar to how it is done in POEM for achalasia. Again, the procedure is performed under conscious sedation. There is no need of prophylactic antibiotic. Complications, bleeding, mucosal perforation, gas dissection, they are less frequent than FESD. Okay. What is POES? Peroral endoscopic septotomy. Okay. It is a modification of Z-POEM where the mucosal entry is directly over the septum. So, okay, if there is a septum here, you are entering the mucosa directly over the septum. Okay. In Z poem, you are entering the mucosa away from the septum. Here you are directly entering the mucosa above the septum. It avoids proximal tunneling at the pharyngeal level. The operative time is shorter. Technically it is simpler. You can do it as a OPD procedure on the same day or keep the patient overnight and send him home on the next day. Complication profile is similar to FESD, but overall complication rate is less. Okay.